Welcome to Live with Nekky Jamal. It is an honor for me to have my man, Dr. Raymond Zhu, on the show today. And this guy is like the super GP I wish I was, because I have no game compared to this guy. I know how to take out teeth, but this guy knows how to do it all. And if you've ever followed him on his posts on Dental Clinical Pearls, you'll know that this guy is legit. And honestly, I think the biggest compliment I can give another dentist is if I would let them work on my own teeth. And without a doubt, Ray, you have my permission to start drilling on these pearly whites here. So, dude, welcome to the show, Ray.
Hey, thanks, Nekky. Thanks for having me here. I'm humbled to be on your show.
Oh yeah, right, man. No, it's an honor for me for you to be on here. But first of all, you got to show me around your office here. I think it's what's going on in the background here, buddy.
Welcome to my humble office here.
Yeah,
which
yeah.
Also has a furnace room.
Dude, this is like the typical COVID office. Hey, like we all had to develop a Zoom room.
This is my facade in the background.
Yeah. No, man,
We
I
actually
love
have
it.
an office upstairs, but that's for my son and my wife to use.
Oh,
I
for
got
sure, man.
relegated to the basement.
Well, that's cool, man. But dude, I want everyone to learn about you, man. I've had the pleasure of meeting you online. I haven't met you in person, but I've followed you along over the years, and you've like, dude, you're legit. You're an awesome dentist. But man, share your history. Where are you from, my man?
Oh, thanks, man. But I think you're being too nice. I'm just your regular run-of-the-mill GP, but I'm a practicing dentist in Toronto, Ontario. I was born in Shanghai, and our family immigrated to Canada when I was like 3 years old, and we
Really?
came around the time that like communism was kind of getting out of control in China there. So
Was it
it was a
hard to leave? Like, was it difficult to leave to come to Canada?
it was very hard, and the neat part is when I hear the stories of what my parents went through and what my grandparents went through, like
Yeah.
to this day, even they don't want to share those stories. But
Really?
as I'm getting older, they're starting to reveal some little tidbits and history here and there. And it's really like, it's humbling to listen to them because you realize how hard it was to get out and what
Yeah.
they had to do and to sacrifice to get out. But I mean, we're a classic immigrant family story. We came to Canada with basically nothing. And
Really?
then we ended up settling in Winnipeg, of all places, Manitoba. A lot of people are like, Winnipeg? Why did you guys settle in Winnipeg? Well, the answer was pretty simple because it was a cheap place to raise a family.
Yeah.
At the
But
time you
like,
came.
did your parents even know that coming over? Like
Yeah, we
usually
kind of
in
knew.
China, everyone's going to Toronto, Vancouver. Like it's not.
Exactly.
Yeah, Winnipeg. I
Well, I
wouldn't.
mean,
Okay.
we had our uncles come first, and
Oh,
they
okay.
kind of settled in Winnipeg. So we kind of knew that the city was an easy place to raise a family. Um, but yeah, my parents, my dad was a pediatrician, mom was like a chemical engineer. They both had to give up their careers because communist China didn't really look highly upon the educated.
Isn't that nuts though? Like, could you imagine as a grown adult now, Ray? Like, you have your own kids. Like, could you give up your career just to move to a different part? Like, I couldn't even imagine doing that. And this
I
is
know,
what your dad did.
I know. I mean, and especially coming here with no English, right?
Oh,
Yeah,
I never even
yeah.
thought of that.
So
Yeah, yeah,
yeah. When you think back and you're like, if we were put in the same position, could you do it? I think the reality is you could, because you're forced to,
yeah.
right? The stories of their parents being shot in the streets and
What?
things take. Yeah. These are the stories that start to creep up,
Oh,
right?
yeah,
It's life was definitely not easy for them at that time, for sure. Yeah,
yeah.
and then
Isn't it
yeah,
crazy how people draw these like parallels to communism and life back then to now how COVID restrictions are? And you're like, are you guys even kidding me?
I know
Like, how is this
exactly,
even slightly similar? Like, get off of me. You know
exactly,
what I mean?
and I say that all the time. I say that all the time. Yeah.
Yeah,
So yeah, we grew up in Winnipeg. I spent like 20 plus years there. Ended up doing my dental school in Winnipeg as well.
yeah.
And that's that's kind of where my career started.
At
it's kind
what
of
point
funny.
did you want to be a dentist? Like, how did that come into play?
Well, I mean, dental. I mean, a lot of people don't know this, but dental was not at the top of the list. You know, at the time when we were picking a profession, I ended up applying to both dental and medical school
Yeah, I
the
think a
same
lot of
year,
us did.
and
Yeah,
I ended up getting into both. Right, and
yeah, yeah, yeah,
my path was totally set on medical school,
yeah,
just because my dad was a pediatrician.
yeah.
But then it was this very last minute decision. I mean, we had some family friends who gave us some ideas, but it was a very last decision to be like, nope, I'm going to dental.
Really?
And then we never looked back, right? So it's,
Wow.
that's the past, right? But I mean, our story kind of, it's funny. I don't know if you watch the stand-up comedian Ronnie Chen, but he jokes about like how Asian parents want their kids to be doctors, right?
Yeah, yeah,
So
yeah.
so when you think back on it, it's funny how it panned out. But you know what? It's a blessing to be in this profession, 100%.
Totally. And like, I know you're referring to your type of Asian, but I don't think my type of Asian is any different because our parents are asking for the exact same things. I think it's the immigrant story, man. Like, you grew
I
up
know, I know.
first generation immigrants. You're like, your kid's gonna become a doctor. That's just how it
But
goes.
that's right. Yeah, yeah. What did Ronnie
Yeah,
say? Instant credibility, right?
yeah,
Instant
yeah,
respect.
yeah. Instant respectability, and then you get into dental world, and you're like, huh? Looks like these doctors don't give a shit about us anyway.
Yeah,
Oh
and then
man, that's cool.
we moved to Toronto, and I'm just a practicing GP here. When I first came here, one of my um, probably best mentors is Dr. Eric Rua. I think he's a member of Bites as well. He basically
Eric,
taught me everything. What's that?
Eric,
Eric, yeah,
really man, such a
yeah.
nice guy, man.
He chose me, and he basically taught me everything I know. So if you think I'm good, then you got to give him all the credit, right?
Oh, I got to get him on the show now. He's a
Yeah,
super nice
100%.
guy. Yeah, no, I like him a lot. That's wicked, man. Okay,
Yeah.
so and how many kids do you have now?
Just the one boy. Just
Just
the
one,
one
and
boy.
how old is he?
He just turned 6, like
Just
yesterday.
turned oh, happy birthday, man. That's awesome, dude. Well, that's wicked. And now you are opening up a new office. Like you just purchased an office, hey?
That's right. Yeah, I know we were talking about it the other day. Like we just purchased it. Like now it should be about just the past a month.
Yeah,
So I'm knee deep in the thick of it.
really.
But it's been fun. It's been good. This would be my time to get back into the ownership game again. So
Yeah,
it's
man.
good.
You know who I want? Speaking of ownership, we had Hisham Shergan on a couple of guests ago. That guy, he's just a genius. Anyways,
I
he
know. He's
introduced
brilliant.
me to this app called Carelytics, and it's a game changer, man. I got to bring on the founder of Carelytics on here, and it's super cool how it's like a practice display on your computer. You know where every dollar is coming in. You know it like breaks down every procedure for you. Everything's like on these graphs. It's like how Moneyball was for the like Major League Baseball. You know that movie Moneyball? That's like Moneyball for dentistry. And it's genius, but we won't talk about that today. We'll talk about that another day. I want to honestly, like, I'm super humbled by your skills. No joke. I'm not blowing smoke anywhere because I think a GP has to be the ultimate badass because you have to be good at endo. You have to be good at prosto, at implants, at surgery. You have to be able to think on a moment's notice, and you have to always think outside the box. And dude, you're incredible. I honestly, I would let you work on my own teeth, man.
Thanks, man. I mean, like I said, I think you're being too nice. Like I don't think there's anything special I do. I think there's that old saying, it's like jack of all trades, master of none, right?
No,
Well,
no, no.
I
That doesn't
mean
apply to you, man. That's me.
that's me, right? And that's why, like, I'm more impressed by guys like you who've really mastered surgery, and guys like Mark and Bernard who's really mastered the implant field. Like, I'm humbled by that, and that's what I strive for, and that's what I try to get better at. But as a general practitioner, I do have to do everything else, right? So
Well, dude, I want the world to learn some tips from you today, because I think you have a ton to share. And just from our like 5 minute convo a couple days ago, I was blown away by the cases you were showing me. And they're like, man, I would have pulled that tooth. I would have pulled that tooth. I would have pulled that. And you're like, nope, saving this, saving this. I'm like, oh shit, my patience. Okay. Dude, why don't you share your screen and let's go over some tips, because I want to talk about cracked teeth. I want to talk about how to save teeth that are broken off at the gum line. I want to talk about caries. Like, man, let's just dive into it here. Let's give people a show.
Sounds good.
Yeah, so I'll
Let me
get you to
see
share
here.
your screen here. Yeah, you just got to open up your keynote there. But yeah, it was. I was telling Ray today, I had a patient. I wouldn't take out their dad's teeth because they had severe emphysema, and he just completely lost it on me. And we were just sharing how no matter how many times you go into an operatory with a smile on your face, some people will continue to try to break you down. And I was like, man, I don't know what to tell you. Your dad has to be seen by a medical professional, not just me. So we were just chatting about that earlier. But anyways, are you ready to share your screen there, my man?
Yep. Can you see it?
Perfect. Yeah, I can see it.
I guess the story of how I started my journey to try and save teeth really started with my mom. I often share this case with a lot of my colleagues. My mom has, I think, about like 17 implants now. And a
Yeah,
lot of
man,
these,
look at all those implants in there, eh?
I know, actually, it's an awesome case study because I think there's like 4 or 5 different brands in there.
Did you get to place any of them?
No, these were all done in the early 90s,
Oh,
and
really?
they were actually done by a pretty world-renowned surgeon in the US at the time. And, back in those days, I mean, in the 90s, it was common to hear like, oh, you do dental implants and they're good for the rest of your life.
Isn't that the truth? Like, I heard that my old boss used to say that. And then as patients are coming back, they realize, nope, I want my money back because he told me that this was good for life. And now I'm like, I can't, what do I even say to that? You know what I mean?
I know. And that's the thing. It's like, some of these implants are approaching 30 years old now,
Yeah.
but we're witnessing, the true outcome of the implants decades later, and I mean, we've known about peri-implantitis for a long time,
Yeah.
but it's just, this is the real life manifestation of it, and yeah, I mean, it's troubling to look in my mom's mouth and see like half the implant is showing.
Yeah.
And often she's getting like some perial abscesses, and that's the sad reality. Now my mom is like 77 years old now, and we're looking at the real possibility that she's going to need revision soon.
Oh, man. Okay. Okay.
But I mean, I've already talked to Mark, and I said I'm going to fly my mom to Vancouver, and let Mark take care of my mom. Let Mark and Bernard do their magic.
Yeah. So are you kind of wishing that you saved some teeth?
Well, that's the idea. I think, just like I think, when I witnessed Mark's reflection on his implant journey
Yeah.
and Mark's desire to try to improve and perfect his implant skills, I took the opposite approach. I dedicated my career to trying to save teeth, because the philosophy in my practice is trying to delay implants basically for as long as possible, because my mother had most of these implants done in their 40s, right?
Yeah.
So now she's in their 70s, and the sad reality is she's probably going to outlive these implants, right? But if she had these implants done in her 60s, then the reality is probably they would have survived the rest of her life, right?
Man, and
So,
that's humbling to think that we as dentists, that was our treatment philosophy. It was, why don't you just pull the tooth, put this implant in there, without knowing what happens 15 years, 10 years down the road, because we were just so excited that a new option was available. And let's be honest, even now, like, no one cares about other CE other than implant CE, because implants are sexy. You know what I mean?
yes.
And
Yes.
the one of the reasons why I think you're such an incredible guest here is because now you're taking the opposite approach. You're like, you know what, implants are cool, but we have to learn to take care of the teeth, and that's really why I wanted you to come on here. And so let's jump into your first case here.
Yeah. So, um, so I guess today, for the sake of time, I'm just talking about a few specific topics. But I just wanted to chat a little bit about what endodontics can do, and let's look at the first case.
Yeah.
Yeah. So I think for me, like
Oh my
endo is one of those things.
God.
Like for me, endo is one of those things. Like we all practice endo to some degree every day in our practices. I know a lot of my colleagues do as well.
Yeah.
But I think what endo might be undervalued is appreciating what it can actually do and the indications when we can actually use it to help. Um, Endo for me, like you've probably seen a lot of my endo treatments. Like I've dedicated a great deal of my time to trying to perfect endo to the best of my abilities because for me, endodontics is the foundation for restorative dentistry, right?
Mm-hmm.
Um, like if you can heal the bone and the periodontal ligaments, then really I just have to worry about the tooth on top, right? And what I found over the years when it relates to endo is the size of the lesion. This is a good example. Is like when you see a lesion of this size and that dark, like that's what we call a through and through lesion, right?
Totally. Yeah.
That bone loss is from buccal right through the palate, right?
Totally.
And you can see like even with this treatment, I can heal the lesion. There wasn't even apical surgery, nothing. It was just healed completely with endo.
Dude, that's absolutely incredible.
Yeah, and I mean, like my perspective about this also is like, can you imagine putting an implant into that lesion, right?
But don't you think that that's where dentistry is going right now? Because everyone is so focused on immediates. Everyone is so focused on immediate implants, now treatments. Treatment has to be done with an implant and it has to be done yesterday. Do you know what I
That's
mean?
right. Yeah.
And I think
Yeah.
that's where dentistry is starting to slowly go downhill because now it's all about getting an implant into a spot that isn't adequate for an implant. And then it's almost a badge of honor to show that you have put an implant there when it really shouldn't be. Do you know what I mean?
Correct. And this, I mean, hey, don't get me wrong. This, if you try and put an implant in that's a beast of a procedure,
Yeah.
right? To manage that lesion, and I mean, if you can do an immediate in that, I mean, I
But
tip
you're
my
going to
hat
get
off.
those people that say, that is the treatment for this. And then
I know.
I don't know. I totally respect that. Now, to be honest, if I looked at that tooth, I wouldn't know what to do. I would probably remove it and talk the patient into doing a bridge because I don't think I'd be able to save that tooth. I wouldn't think I had enough, ferrule to save that tooth after you remove that crown. There's just nothing left of it. You know what I mean?
Yeah, yeah. I mean, this case, I think is approaching 10 years old now, and I mean,
That's wicked,
I think
man.
the other day that's still a temporary crown because I didn't know if the lesion would heal. Right? So
Dude, that's incredible, man.
this is my, I mean, at the time, this was my proof to myself that it can work and it can heal. And the reality is, this was 10 years ago. Nobody would know what the outcome would be until time passes, right?
Yeah.
And that's what I learned, like with over the years with endo, like the biology, just like implants, the biology will dictate whether the lesion can resolve. And our only goal with endo is to create the environment to allow the biology to heal. And if you
Yeah,
can
fair
achieve
enough,
that,
man.
yeah,
Dude,
and if you,
was this a two-step endo with calcium
actually,
hydroxide or
this was a one step.
what? Man,
This is
I
a,
told you he is super GP.
yeah.
I'm humbled, man. That's amazing. One step endo. Okay, okay. You're throwing
But
everything out
again,
the window now.
that's that's beside the fact. I mean, the studies all show one visit versus two visit, the success rate's all about the same. For me, this is like just like implants. I respect biology, and I respect that the biology allowed the patient to heal.
Yeah.
And this was the first step to saving the tooth, right? So I think
Mm,
for endo, because when I speak with a lot of colleagues, the vast majority of people don't actually like doing the endo. I think it's something that I like to encourage colleagues to have more appreciation of, because for me, like I said, this is the foundation for restorative dentistry, right?
fair enough, man. But that's absolutely amazing because when I see cases like this, I automatically assume it's a cracked tooth. And then I'm like, you know what? The tooth's shot anyway. So you might as well just take it out and then let's come up with another solution.
Well, I mean, that's a good segue. So let's talk about the second case, which is cracked teeth, right?
Oh, dang, man. You're on point today. I like that. I like that.
So that's a good segue to the cracked teeth. Now, like cracked teeth, for me is like it's one of my favorite topics because there are no good studies to guide us to when we should treat them and when we shouldn't. I mean,
Agreed.
there's a couple handful of studies that talk about survival rates, but most colleagues, when we talk about it, a lot of people are hesitant to treat. And
Yeah.
actually, the truth is, even speaking with a lot of my endodontist colleagues, many of them are hesitant to treat these. Like, I can guarantee you, if an endodontist saw this type of crack, they'd be recommending extraction.
And
Uh,
Ray, you're 100% of the time. You don't know how many letters I get back. Because I'm like you. I try to save the tooth. Sometimes if the patient's a little unsure, I'll send them to an endodontist. I'll be like, hey, listen, what do you think about doing an endo here? 100% of the time, I get a letter back. Necky, pull the tooth, do an implant.
that's
And
right, yeah. Because
and
they're
after
nervous.
talking to you, they're nervous because then you have
Yeah,
to redo a procedure for free, man. That I
that's right.
totally understand that. It's risk assessment, it's risk probability, right? And the probability is that they're gonna be having issues with it.
So that's a great point. So that's where I think being a general practitioner gives me a slight advantage because what happens in my office is I actually treat them all. You
You
know,
treat every cracked tooth.
I treat every cracked teeth. My only exclusion criteria where I wouldn't treat it would be if there's like an isolated deep pocket. So it has to be a very isolated deep pocket, or I can visualize the crack. So sometimes what
Mm,
I'll do is I'll even do an exploratory flap. So if I'm unsure, I'll do exploratory flap. If I can visualize the crack traveling down the roots, then yes,
yeah.
I will pull the plug. Or sometimes if I can even feel the crack with my probe, then I'll decide to pull the plug. But essentially, other than that, I treat them all in my practice, and I go into these cases with no fear because at the end of the day, even if my treatment fails, I can always credit the patient back towards an implant. And because I'm the one placing the implant, I don't really lose anything except a little bit of time. So
Right.
that
Whoa,
in
whoa,
my
whoa. Dude, this you're incredible, man. So you do all the treatment and then no matter what happens, you're like, okay, I'm just gonna credit the patient back if it doesn't work.
that's correct. Yeah. But
Wow,
that's
man.
just my
That's
philosophy. I don't
I knew I wanted you to be my dentist. I like this, man.
Yeah, but that's just my philosophy. I don't ask any other clinician to follow my same philosophy. It's just my way so that I feel like the patient feels like they've lost nothing by trying,
Yeah.
and it's my way to sleep well at night, right? That I've
Dude,
taken care
I
of.
100% respect that. And what you said about the endo too, it's you're trying to continually perfect your skills for your patients and dude, I respect that. I 100% respect that. So, just to recap, when you see isolated cracks, when you visually see it or you have an isolated deep pocket, that's the only time you won't treat it. But if
That's
you
the only
can't
time
find a
I'll
pocket on that tooth, then you'll go ahead and do the endo. And
please.
what's your tips for like, um, will you ever get your crown margin underneath the actual crack, or is it still okay to visibly see that like craze line in there? How do you
Yeah,
deal with
so I
those
mean, you can
scenarios?
only try your best. You can only try your best because a lot of times, sometimes the crack are going quite subgingival.
Yeah,
You just can't chase them into no man's land, right? So I will stop when I feel like I'm invading certain spaces that I don't want to be invading into.
yeah,
So, for example, this one I just ended probably just at the gingival margin, and then I try my best to seal it as best as I can. So, because I treat them all, like over the years, like I've actually created like this pool, this database of all the cracked teeth I treated. So I actually have stats, that I can share with patients and share with colleagues about the success of this because you can't find it in studies, right?
no, you can't.
Over the years, I probably treated like hundreds of these. So I keep this running database with as many recalls as I can acquire just so I can share those. And I've shared them with colleagues, so I guess the first thing is my definition of the crack is it has to be horizontal. Like
Oh,
we all
okay,
see, the crack cusp, where the
right.
cusp is off. I don't include that in here. I call it a crack cusp. Those are actually very predictable to treat. For me, it has to be horizontal, meaning it's going across the marginal ridge, going horizontally. Sometimes it goes all the way through, like this case, where it goes right from mesial to distal. Sometimes it goes halfway. I lump them all together.
So
So
Ray, when you say it's quite predictable to treat a cracked cusp that
yeah,
hasn't broken off yet, would you agree?
no, the cracked cusps, the ones that I'm referring to, would have broken off.
Okay, yeah, no, I totally hear you. How do you treat those ones that are, they have biting pain on the tooth? You know it's coming from the distal lingual cusp. What are you doing in those scenarios?
I try and break off the cusp.
Oh, I totally agree. But
Usually,
how are you doing that?
so I use a round, like a round burr, and usually the vibration will cause it to lop off when during your preparation.
Oh, okay.
If that doesn't happen, then I'll just shoot the cusp down right down to where I can visualize the crack,
Okay, okay.
and then,
No,
and then
that's fair.
yeah, then rebuild it. But these are the cracks where you can't really like, like break off that part of the tooth because they're going horizontally across. And when they're traveling like that, then they start traveling vertically, right? These ones you
Yeah.
can't break off and break the whole tooth.
Dude,
So
honestly, Ray, much respect because I'd be pulling those. So
yeah,
that's amazing, man. So you're treating them. How often would you say that you have to go back and like you said, sometimes you credit patients for the work that you've done if it doesn't work? Like at what point are you saying, no, that's worked well for you for, 4 years? At what point are you like, no, let's just do an implant?
oh, okay. Yeah. So I mean, if the patient comes back with symptoms, for certainly, if there's crestal bone loss, certainly, that's when I'll pull the plug. Those are the criteria that I'm looking for. If the patient's asymptomatic and the radiograph is looking stable, then I deem it a success, and then we just let the years ride. You know.
Man, you're amazing, Ray. I love that,
Yeah.
man. I love that because sometimes when I see cracked teeth, you're talking about the horizontal fracture. But what about the fractures that are right off at the gum line on an anterior tooth? Patient has 100% deep bite. They've had a previous endo on the tooth. What are you doing in those scenarios, man?
Okay. So, I mean, I guess that's the next one here. I'll just share the next one. So that's where we talk about the cash flow. So I think you're referring to something like this, I guess.
Yeah, and like, man, I get it at least once a week, and it's always a patient. They have occlusion issues. They should have had ortho when they were younger. You tell them about, considering seeing an orthodontist now. They tell you where to go, and then
Yeah.
they're in this scenario, 100% deep bite right off at the gum line. And what do you do? So
Yeah.
this is
So
it.
I
Like, what are
mean,
you doing here,
yeah,
man?
I mean, this is a common one. Hey, look, the decision to treat these ones are tricky. I agree. Um, Now, I mean, in this particular patient, this was born out of necessity because she's actually on IV bisphosphonates.
Oh, okay, yeah.
So,
Yeah. So you didn't want to do an implant there.
yeah, so we didn't want to extract, didn't want to do an implant. But I mean, that's besides the point. I approach these all in the same mindset. Now, these ones, I mean, there's a few different ways you could treat these. Like this one, you could actually like orthodontically extrude and to get more ferrule, right?
Have
You
you
can
done that before?
Yes, yeah, you can. In certain situations, I think it's certainly valid. You would do rapid ortho extrusion. You can even do surgical extrusion. I've done that before.
Okay.
Surgical extrusion means you actually pull the tooth, like you extract the tooth, but you only extract it like a few millimeters, and then splint them, all right, and then allow the PDL ligaments to reattach.
It doesn't that like lead to ankylosis?
Yes, yeah. So those are
Yeah.
some of the consequences that you can, but that would be another technique to try and gain a little extra tooth structure.
Okay.
You
Okay.
could do crown lengthening here too, but crown lengthening with these cases will create a little bit of like an aesthetic defect.
Yeah. Yeah. Yeah.
Well, probably the most common method in my office to save these ones is the cast post. So that's basically the topic I want to talk about
Whoa,
for
whoa,
these.
whoa. So you're talking cast post when they're flush off at the gum line, you'll still do a cast post.
Yes, yeah,
How
yeah.
deep is your margin on your crown before you do your cast post?
Well, in this case, it's right at the gingival margin. I don't have to go past
Really?
the hospital. So this, I mean, this now enters a discussion about ferrule, things like that. So, I mean, if we talk about like how typically most dentists will restore this, I mean, everybody will look at this and say, okay, if you're going to make an attempt, you got to put a post. You know,
Yeah.
there's nothing else to hold, right? And in dentistry, I mean, we have our three classic posts. You got your fiber post, your parallel post, and your cast post.
Yeah.
I would say the vast majority of clinicians favor the fiber post, right? But in my experience, and even from witnessing my own failures, like of all the choices, fiber post is probably the worst.
Really? Why is
Um,
that? Why is that?
because they're too flexible. That's the problem. So what happens with a lot of these cases is because you're lacking the ferro under occlusion, the fiber post is actually flexing, and that actually breaks the cement layer, and then your whole crown.
Oh,
Right?
dang. Dude, I've been approaching these all wrong because when I see this, I'll be like, if the patient doesn't want an implant, I'll just send him to one of my associates. I'm like, dude, just throw a fiber post in here, do a core buildup like you've seen on Clinical Pearls, and
Yeah.
snap your fingers. You got a crown. It'll be good for 30 years.
Yeah, the fiber post sadly is the worst. I mean, that's born out of. I mean, there are studies to show that it is not a good choice, but that's born out of my own failures as well. You know, I realized I was
Okay.
doing fiber posts a lot for quite a number of years, but in these situations, they're just not the right choice because they are too flexible.
So here you're doing a cast post
That's right. Yeah,
with
yeah.
no
So
ferrule.
that's correct. Yeah.
Okay.
So I mean, there's also the prefab parallel posts, but they're better than fiber posts. But the problem is they're parallel, right? But your canal is straight, is tapered.
Okay.
So your post is only engaging the tooth in like 2-3 millimeters, and the rest of the post is floating in cement,
You're totally
right?
right.
So, yes.
100%.
So then again, the problem is the cement layer becomes your weakest link. The
Oh, man.
reason So the reason cast post works so well is because the cast post is customized and it actually fits along the whole length of your root. So there is so much resistance form against the root that the resistance form to dislodgement is so strong with cast post. And I mean, this might be a little biased as well because whenever I do endo retreats, sometimes I have to remove these posts. And I'll readily admit, like cast posts are one of the hardest posts for me to remove as well, and for that
Yeah.
reason, yeah,
So when you make your cast posts, are you using like that pattern resin, that pattern GC resin?
that's right,
Oh
yeah.
yeah, like
So
this right here. Yeah.
I mean, like that just goes back to our dental school days where we're actually making these patterns. I make them all chair side, so I make a customized pattern in the mouth. Usually, once you get proficient, this doesn't have to take very long. This takes me about 20 minutes to make. But we all have such bad memories from dental school. That's why nobody likes making them. So,
You're totally right, Matt. What?
yeah.
Okay, now tell me. Say I wanted to make, or say I wanted to take a PBS impression of my post. Is that
Yep.
acceptable in your eyes, or would I
I
get
mean, I've
a
done that
not
as
as good of a
well.
result?
That's right. I've done that as well. In the past, I have done that as a way of maybe saving some time to do it. What I found was the labs weren't making cast posts as intimately adapted as what I could do chair side. So
Totally.
I ended up going back to chair side again. Yeah, just
Yeah.
because I have full control. That's right. Yeah.
Because they're
So
they're trying to, because if something's holding it up, the post won't seat and then the crown won't seat and then they're doing everything again. So I can see why the lab wants to incorporate a little bit of the
yeah.
flexibility in narrowing things out a little bit. So I totally hear that, and I think that's one of the mistakes that I used to make is I would just go ahead and take an impression because my pattern skills like with that GC resin suck. And they weren't like I tried it once in dental school. I didn't try it again, right? So I don't have those skills to do it. So my post probably never fit as well as I wanted it to. And you just nailed it right there, man.
Oh, I'm sure you have the skills. I have no doubt.
Man, that's
But
wicked, dude.
yeah, so I mean, if you look at this X-ray, I mean, you can see the intimate adaptation of the post. That's really where I find the strength of it comes,
Yeah,
because it's got such resistance form because it's engaging all on the whole walls. You barely need any cement, right? So at the end of the day, when we talk about ferro, ferro is this I find amongst clinicians, it's a very poorly understood concept. We're trying to think of ferro as if it's taken like gospel, right? But really, at the end of the day, what you're looking for is the retentiveness of your post and your cast post core has to be greater than the force of dislodgement. You know,
That's right.
and
Yeah.
if it is, then your crown's going nowhere, right?
Man.
And at this point, my cement no longer becomes the weak link. You know, the cement's the weak link for your fiber post. The cement's the weak link for your parallel post.
Yeah.
The cement's not the weak link here. I always tell people, it's like the weak link here is actually the root. If this is going to break,
Yeah.
it's the root that will break first. But I'll be very honest with you. The studies show cast posts break roots more. I haven't seen it clinically.
Yeah.
And it's not something that I'm concerned about because I have not witnessed it clinically. I think it's just one of those where the studies are saying one thing, but I'm not certain it's translating to clinical.
Man, fair enough. Dude, you're blowing my mind here today because I honestly thought there was no way around this and I would be losing that tooth. So
Right.
that's wicked, man. Look at that.
Yeah. The only other concern I guess some people have is, what can you do to hide the post? Because, it's,
Yeah, good point.
yeah. So, I mean, I use different materials. There's zirconia that can mask the post pretty well. There's different ingot selections for Emax. I mean, with good communication with the lab, hiding the post is not a problem as well.
Do you ever use those like opacers over the post?
Yep, you can. I find they don't, some labs will put an opaquer layer. To me, it doesn't even look natural anyways.
Yeah.
So I usually try and go for opaquing either internally in the crown, or we use a coping that's kind of blocks out the hole.
So not the whiteout that I tried. Dude, I've tried it all, man.
That probably would work, yeah.
Okay. Dude, that's wicked, man. That's badass. If you could do that predictably, I think we could save our patients a lot of grief because not everyone wants an implant, man. And I think you did a service. So how long would you say you would get out of a tooth like this on average, like in your office? What was your success?
So I'll tell you this. I mean, it's nice that I've been in the same location for over a decade now. I would say I have not really witnessed any failures of my own cast posts, but
Really?
time always has to speak the truth.
Mm-hmm.
So with enough time, if 20 years passes, 30 years passes, then yes, I can safely look back and be like, man, this was a great service. But I'm only 10 years in, right? So the longevity is not quite there yet. But what I also like to do in my practice is I like to pay attention to cases that pass through my office. So for example, like I have patients that have cast posts in their mouth that I didn't do. But very commonly I'll ask the patient, I'll be like, when was this done? And they'll be like, oh, that was done like 25, 30 years ago.
Really?
So I'm using also my pool patients to kind of get a sense of longevity because a lot of these cast posts, when I get to say remove the crown and look at them, I would say the vast majority have no failure.
Really?
And
Man, that's incredible.
That's my internal proof to say, these things are a beast. They'll hold for a long, long time.
Really? Man,
we just have to learn
awesome.
to make them properly.
Dude, I learned a lot there, and I really hope maybe I'm gonna come down in Toronto. You're gonna teach me my pattern resin skills. I could use a lesson.
Yeah, man.
I really feel like a lot of the techniques from dental school, I really wish I would have paid more attention. But no, that's awesome. So after cast posts, let's talk about dentures, man.
Yeah.
But not traditional dentures.
Yeah. Yeah. So the next topic is the telescopic overdenture. Now this treatment, I think, might be one of the most underutilized and underappreciated techniques. And in my opinion, when someone still has some remaining teeth, I think telescopic overdentures should at least be in the conversation as part of an option to help a patient maintain and save some of their remaining teeth rather than jump to extraction and all on X. I just think it should be part of the conversation. It may not be the right treatment for every patient, but I think in the right circumstances, it can be very good.
Raymond, you're blowing my mind here because
Yeah.
I'm guilty of the dude saying, "All right, Mrs. Smith, it's time to lose those teeth, and let's get you a nice fitting complete upper denture. You don't want to do implants, so you're getting an upper denture." Because I'm not gonna lie, I would have taken out those teeth because of the recurrent caries, the bone loss, and there's only like
Yeah.
what 4 teeth remaining. So
That's
this is
right.
phenomenal. Okay, so now what are you doing here, man? You have to
Well, I
do an
mean,
endo first.
endo first. There's a reason for that too, because you have to cut quite a bit of the tooth to make room for the telescopic overdenture. So, what it is basically is it's kind of like a crown that fits on top of a crown. The analogy there is like you think of like two paper cups together.
Yeah.
They've got some independent like suction almost, kind of like friction when you put them two together. Well, that in essence basically is what a telescopic overdenture is, where you actually place what we call a telescopic crown. So that's what you see as the metal crowns there.
Mm-hmm.
And then there's a secondary crown that goes inside the prosthesis. So basically, those two actually fit together. And that's what actually creates your retention.
So it's a cup on
And
a cup. I like that.
it's a cup on a cup, basically. Yeah. And the reason I like this, and the indications where I recommend this option would be patients where they have, say, a few remaining abutment teeth, but they're still pretty favorable. Like they still have, good perial and good bone support, no mobility. They might be even oddly spaced out so that you can't really offer any other options.
Yeah.
Then that's when I think this treatment really shines, because it doesn't really matter the position of the abutments. You can put coping crowns on all of them
Yeah.
and use whatever remaining abutments you have to create this friction fit.
Hmm.
And I'll be honest with you, the patients who have these prostheses, they all love it, because to me it's as comfortable, or if not even more comfortable, than if somebody had locators, right?
Dude, this is
And
incredible. Can you give me dimensions? So, like, how tall do one of these have to be? Like, spacing requirements.
so the spacing requirements. So this is where, when you design telescopic overdentures, like you need a lab that knows how to design these properly. Because
Yeah.
the truth is, these are actually incredibly difficult from a laboratory perspective as well. So you need a lab technician who's actually skilled. And thankfully, we have a guy in Toronto that I thankfully just recently found that he's amazing. He knows exactly what to do for these cases, but that is part of it, because it's this communication with the lab that is very critical, because the spacing you require also is dependent on what material you choose.
Yeah.
So what I mean by that is, like here in this case, I used an acrylic denture,
Right.
right?
Yeah.
Well, you need room for two telescopic kind of crowns, and you need room for the acrylic, and then you need room for the denture teeth, right?
Absolutely. Yeah.
That's a lot of clearance, and that's why I ended up having to treat these endodontically, because by the time you reduce these teeth down,
Yeah.
you're into the pulp, right? So,
Totally. No, but like, because like I find sometimes denture teeth can break if they're not thick enough, but now we're including another coping plus the telescopic crown.
yeah.
Um, do you
So the
find in
military,
situations where you're opening the bite more, like this works more because you can get thicker distances there? Yeah.
yeah, sometimes you are opening vertical, but nowadays the modern day combination that has become more and more popular is you would use these metal coping crowns, but they'll actually put a peak framework on top.
Ah, okay, okay. And hey, Ray, have you ever done a Galvano secondary? Someone asked that on
Correct. So,
Facebook.
so Galvano is the most traditional. So Galvano, technically, if you can find a lab technician that knows how to do Galvano, they're amazing, right?
What does
Because
Galvano mean? Fill me in, man.
it's basically it's a type of special treated gold crown. It's basically a special treated gold crown, and the reason the Galvano works is, over time, with the friction fit, it just keeps fitting better and better. It's kind of like I'm not even
Really?
sure how it is treated in the lab, but the Galvano crowns, actually the fit gets even better with time. But the problem
What?
with galvano is it's actually very expensive to make because of the
Yeah.
gold
Yeah. Yeah.
cost. Plus the technique sensitivity to make galvano, like few technique, like you gotta be like German trained
Fair
to
enough.
actually know how to make them. So, like I said, the more common one these days is they're milling the abutments and the peak framework, so that the fit is basically as good as what you could achieve back in the days with galvano. That's right. Yeah.
Hey, what about like when you put these crowns on there? What about caries, man? Like a lot of the situation how they got in this mess is because of poor oral hygiene and dental caries, and now we're going to be locking in a denture on top of
Yeah.
that. Like how have you tackled those situations?
So although I agree, this is my one of my favorite techniques. Like it comes with disadvantages as well. And I think you touched base on one of the big ones, which is caries.
Yeah,
So I think this picture here shows like I do watch these coping crowns very carefully over the years, because recurrent caries is probably the number one reason why this type of prosthesis will fail. So in these cases, how I try and mitigate it here, you'll kind of see how I buried the crown margins like subgingival.
yeah,
Uh, so what I'm trying to do is shield the tooth from the oral environment. We get patients on a high fluoride toothpaste. Certainly, regular recalls are critical. Those are all important, because at the end of the day, if the caries destroys the teeth, then yeah, they're looking at implants now, right? So
yeah.
I do agree. To me, the disadvantages of this type of treatment, although it's fantastic, is it is very technique sensitive. You need a great lab to work with to do it properly. It can be expensive as well, depending on how many abutment teeth and the recurrent caries. I would say those are the three big things to be mindful of when we're considering the option. So
Man, that's incredible. I got to, next time I got a case, I'm going to be posting it up and I'm going to be expecting some guidance there, Ray. I like this. I want to definitely try this, man. So,
yeah, I'm
what's,
actually working on one now. Yeah, I'm working on one now that has like six lower abutments, right?
whoa,
I'm gonna try and document it as well as I can. But can you imagine like six abutments? The amount of resistance form I can achieve with six. To
totally.
me,
But
it's
to
like
me, it
it's
seems like it would be a draw issue, man. Like that's what I think is going to be difficult. No?
well, your draw will be created by the coping crowns. The lab will make them all parallel, right?
Hmm. Hmm.
Yeah,
No, that
and
still seems
they'll
difficult.
yeah,
Dude, that's incredible, man. Good for you. That's wicked. Thank you for sharing that. But man, you know what I'm going to ask you next, because this haunts me. Because
yeah,
my practice is 100% sedation. So I mainly do, third molars. I'll do full mouth clearances, but sometimes I'll get people asking, you know, uh, I have a ton of fillings to do and I get nervous because I don't like doing, 20 fillings in a row. That's too stressful for me. Um, what,
yeah.
what do you, what do you do in situations where you have super deep caries and it's super subgingival?
All right. Sorry, bro. I'm just
No, did you plug in your
my
computer
dad is
there?
playing home, so I'm just trying to plug it in before I die on you. Hold on one second.
Yeah, yeah, yeah. Dude, I've been there. Man, today I had to do 7 fillings and it took
Yeah,
me longer than any of my other appointments and it stressed me out more than anything because they're so
yeah.
this exact same scenario. It was like I was channeling my inner Dr. Zhu to try to fix these caries that are like 3 mils sub G. What do you do in these scenarios, man? I honestly, I'm like, just use some fluoride and delay it for as long as possible because I can't fix it.
Well, I mean, I suppose. I mean, you could use SDF. I mean, it's a way to do it. But I mean, we've talked about this before. The truth is, there's no magic in what I do. Whenever I do these, I struggle just as much as any other clinician. So they're just very difficult. They're difficult for access, difficult for visualization, difficult for isolation. They're challenges so that, like, I've never met a dentist who loves doing these, right? But I think what makes it maybe more tolerable is to have the right armamentarium to do them. And that's really what it comes down to. I guess that's anything in dentistry. It's like if you have the right tools to do it well, then it doesn't have to be as miserable as it may seem. So for me, I have certain strategic subgingival that for me was a game changer when they came.
Hmm.
Nekky?
Yeah, yeah, I see ya.
Yeah, yeah. The diamond wedges was a game changer for me because it had the right shape to get subgingival to isolate.
Where do
And
you get
then
the
for
diamond
me,
wedges from?
they're from BioClear. BioClear.
Oh, okay, yeah, yeah, yeah. So they have different widths, eh?
Yeah, yeah,
It-
yeah. I use the green one quite a bit because that's their subgingival wedge. Because before, with all the other wedges, it would deform the matrix, right?
Absolutely,
Um,
and then you get the notch in the filling.
exactly. Yeah. It didn't. So these were a game changer for me. And then for me, I would say in the last 5 years, Activa Restorative has been the game changer because this material, for whatever, well, I don't know what secret ingredients they put in it, but in high caries patients, that's all I use, and the years have proven success in those type of patients.
Really?
Basically, what it is it releases fluoride, and I mean it's kind of like a GI in that respect, but it's stronger than the GI. It polishes better than the GI. It handles better than the GI. So it has everything better about GI, and it works really well in these high risk patients.
So
Sometimes though, yeah, yeah, go ahead.
So, like when you put your matrix in, you're using your green diamond wedge. Your what type of like bond are you using? Are you like sixth generation? Are you like old school fourth generation? Like what are you doing?
I mean, I use a fifth generation. Fourth
Okay,
generation is probably it's still the best. It's just
yeah,
I found
too
fifth
long.
generation in my hands has worked very predictably, so that's what I use. I'm not a big fan of sixth, seventh generation. I think once you start trying to skip too many steps, I'm not convinced it's actually better for the outcome.
Yeah,
So I still do total etch everything and regular bond, nothing special about my bond, and then I just put the Activa in. Um,
is it a multi like is it a layered product or how do you do it?
Uh, yeah, it's a little bit of a layered product. Yeah, I tried doing bulk with it, and it was a mess. It didn't cure properly.
Oh, okay,
So
okay.
nowadays I layer it in like a couple of millimeter increments, and I mean
But
it's fast because it behaves like a flowable, so it restores very quickly.
I'm looking at your X-ray here, like on the 1615, and I'm literally drooling, dude. You that I wish I knew how to do that. That is
I mean that's
absolutely
like
incredible,
it,
dude.
it's I just use the matrix to my advantage, and that's what it is.
So
I
let's
mean,
talk about these matrices. Because
yeah,
my matrices, there's no way in hell I could use that. I'm using the like in our office, all my associates, they're like, man, let's get the trio dent. There's like a green, a blue, and a purple. And
right.
I personally, I didn't even know that there were other types of matrices out there. Like I had no clue. So I'm using these, and then every
Yeah,
time I stick a wedge in there, and then I'll take an X-ray, you'll see like this lip, and then I'm like, you know
yeah.
what? Screw this. I'm just gonna take out third molars. You guys do these fillings because I don't know how to do them.
Yeah, no, I mean, mine, the picture shown there, it is the Trio Dent, but it's the Trio Dent original. The metal ones. Your associates are buying the what they call the super curve. But the problem with the super curve is that the curve is too exaggerated. So what happens is when you put it in, it deforms. So I found the original metal ones were a little bit more resistant to deformation, and then the wedge selection is the key in your case if
It's the
you're getting
wedge
people.
selection. So you're mixing the trio dent and then you're using the BioClear diamond wedges. And you said the most common color you're using is green?
For if you're doing these subgingival ones, yeah, yeah.
Yeah.
For your
Okay.
other ones, you can use different sizes that fits your what you need. Now, in this case, I did an occlusal approach because access to those caries is nearly impossible there. But sometimes I'll try like a tunnel approach. So a tunnel approach means
Oh, you go through the side.
I'll go through the sides. So if access is good, I'll
Yeah.
go through the side, but then I'll use the BioClear. You see those clear matrices.
Yeah.
Because what I'll do is I'll cure right through the matrix.
Right.
You know, yeah. So that allows me to be a little bit more conservative because the problem with these deep subgingival caries is you're drilling through so much tooth just to get access to the caries.
Yeah.
So I sometimes, if I can handle it, I'll use a tunnel approach. And
So in these scenarios, we're often so close to the pulp. When you're doing that, are you doing a liner or are you just going straight to Activia?
I mean, I do
Is it
use therapy.
Activia? I thought Activia was the yogurt. What is this
I
called?
know it is a yogurt. It is a yogurt. Yeah, Activa. I call it
Activa.
Activa.
Activa. You know what? They're both good for your colon health, so I love it.
Yes, 100%. But yeah, no, it. I mean, I do use liners. I use Theracal in my practice there. But I find, uh, I mean, this is a different topic altogether. But I don't end up needing endos a lot on these the deep ones. I find it's a combination of just trying to be gentle when you're removing it, not to be too heavy-handed. Just try and respect the tooth and the pulp as much as you can.
Yeah.
Even these deep ones are very predictable, I find. So
Wow, man. Dude, but like any other tips when we're tackling these ones when they're so deep? Like, how are you even getting your drill down there? Isn't it bleeding a ton? Like, what are you doing here,
yeah,
man?
I mean, I don't know if there's any tips because it is like I said, I'm in there grinding away, just like every other clinician. This is like I'm sweating in there and I'm working hard. I think the only thing is, the what might set me apart is I can't accept failure. So I have a lot of grits when I'm doing these, and I'm really focused to try and do them well. And I just try my best. But the truth is, and I mean, I'll share it one day. Like, not all of them turn out very nice. I did some the other day that turned out very ugly, but it's because they are that difficult, right? And
Totally.
I have no shame when they turn out ugly because I know I try my best.
Dude, I love your dedication, man. Do you use a rubber dam when you're doing these?
Basically for everything. Yeah, I use rubber dam for almost everything. I've even used rubber dam for extractions. So
What? Tell me about
yeah.
that.
Oh no, it's
How?
just
What?
I mean, that's just silliness. But like, say I'm working on an adjacent tooth. Like, say if I'm working on tooth number 47,
Yeah.
but 46 needs to be removed, right? Well, a lot of times, I extract as the very last procedure before I let the patient go.
Yeah.
Once I'm finished restoring the 4-7, the rubber dam's already in place. I'll section the tooth with the rubber dam on and take out the teeth.
Nice.
And your tongue, your cheek, everything is protected. You got great visualization. I use rubber dam for everything. Yeah.
That's funny because we're completely the opposite. Because since I'm doing it under sedation, I pull all the teeth first because that's the thing I don't want them to remember. And then if there's
Yeah.
like 4 or 5 fillings to do, I try to do everything at once. And
Yeah.
then like you already pulled the tooth, now you're struggling with blood, patient that's moving all over the place, and deep caries, and then you start to sweat, man. Let me tell you, for all my sedation dentists out there, doing these under sedation is hard, but
Oh, yeah. See, I don't
I'm going
know.
to take some of your tricks.
See that I don't know how you do it. I've worked with patients under sedation. It's not easy, right?
No,
Yeah,
no.
because they have no control, right? And they're moaning and they're moving around, right?
Yeah.
So
Oh, I got my fair share of stories. It's all been fun, man.
yeah,
Ray, that you took us on a real adventure there, man. We went from endo, no matter how big the lesion is, treat it, right? And then we went to
yeah,
cracked tooth, and you told me you treat every single one of these teeth, which blew my mind away. Um, and man, then we went to Caspol's course, which I'm still I need to learn that GC resin. We went to telescopic dentures, and then to caries. And I hate to say it, you showed me 5 things that I do not do at all in my practice. And so I'm kind of embarrassed as a GP that I need to step up my game, man. But this is why you're super GP.
well, that's why we share stuff, because hey, look, do you know how much stuff I've learned from watching your wisdom teeth extraction videos?
Oh
It's
yeah,
like
right.
I was blown away. I was like, I had no idea I could do that, right? So I mean, in the spirit of sharing, like, I appreciate you and all that you've taught me. It's I'm in marvel of what you do too, right? So
Well,
I'm just happy that we can all share together, right?
yeah, man, dude. If I organize a CE event in Toronto, headlining you, I would. I bet you we could sell it out in an instant because I can guarantee you just taught us 5 topics none of us are doing, or doing them efficiently or effectively. So, Ray, honestly, it was an absolute honor to have you on today, and thank you so much for coming on.
Thanks, man.
Yeah, it was it was great. So I hope to see you guys all next week. Thank you so much for tuning in to Live with Nekky Jamal, and we'll see you guys soon. Have a great day.